Well, thanks so much for having us. I'm Andrew Barr with GreyMatter Capital. We're a venture capital firm that invests in all kinds of usually technology-driven innovation in mental health, behavioral health broadly. And so, the topic of this conversation is going to be technology and its impact on this broader system. And so maybe just as a start, we can have each panel introduce themselves and dig in from there.
I'll go first. Yes. Hi, everyone. Good afternoon. Thank you for sticking through this amazing day to listen to us. My name's Dr. Tully, they, them pronouns. I am a clinical psychologist by training, and I now am the VP of Partnerships at a company called Kooth. And we are the company behind the platform Soluna. And if you haven't heard about Soluna yet, let me tell you what an amazing program it is. The state of California recognized as part of the Children and Youth Behavioral Health Initiative the need for a digital strategy for young people to access care in this state. And Soluna is part of a collection of programs, including our sibling program that Noah will be talking about in a second, to provide free access to mental health support on any internet-enabled device. We serve everyone from 13 to 25, and they can access self-guided resources and coping tools, a safe peer community forum, one-to-one coaching with real certified mental health human professionals, and care navigation to get them connected to other resources in their community. So if you have young people in your life, if you're serving young people as part of the work that you're doing, and you don't already know about Soluna, please come and find out about it because it is free. You don't need a referral, you don't need insurance, you don't even need to tell us your name, you just need a California zip code and a date of birth. And I think this is a really amazing way of leveraging technology to open access to every young person in the state, and that is kind of the angle that I'll be kind of coming at this conversation from. Thank you.
Hi everybody, Elise Wittick. I'm the Senior Director of Partnerships at Elios, and I'm also a licensed clinician in the state of Washington. Elios is a platform utilized by over 250 organizations across the US to help support clinicians in their administrative work and support the compliance as well. So if you're not familiar with this type of technology, it is AI-driven, more like an AI scribe, where during the clinical conversation, Elios is actively listening to the conversation, processing it in real time, and then destroying the record. So no transcription, no recording of that audio. But then at the end of the day, when that clinician has finished their 5 back-to-back sessions, they open their EHR, their EMR, and key moments from all the conversations are customized for their workflows, for them to write their clinical note, sometimes going down from 20 minutes per note to 5 minutes per note. As a past clinician myself, who was working in community behavioral health with sometimes caseloads ranging from 60 to 80 people, I know what the administrative aspect, that burden, does to the care that you're able to provide. And so that's my North Star, and the North Star of Elios is to support the folks doing the good work out there today.
Awesome. Hi, everybody. My name is Dr. Caroline Fenkel. I am the Chief Clinical Officer and co-founder of Charlie Health. Charlie Health was founded on a mission that we want to connect the world to life-saving mental health treatment. What that means is many individuals end up on wait lists. Many individuals have extremely high deductibles, co-pays, and we at Charlie Health are as dedicated as possible to those people that need help, specifically those who are struggling with issues where they need more than once a week therapy. We call that intensive outpatient programming, and that is for individuals so that way they don't go to the emergency room. We know that the emergency room is great for physical health care issues and ill-equipped for mental health care issues. So our goal is to help those individuals who kind of are in that continuum of care. They need to be able to get multiple time a week therapy, but also don't necessarily need inpatient. And that's all that I have to say about that. Thanks, everyone.
I love it. What an incredible panel. Good afternoon, everyone. My name is Noah Oldak-Moradian. I am the Director of Community Engagement at Brightline for the Bright Life Kids program. So Dr. Tully talked a little bit about CYBHI and the Behavioral Health Virtual Services work stream. So we are the branch that supports families with kids ages 0 to 12. We also provide one-on-one coaching, digital tools, peer communities, asynchronous support. And I just want to say, in the context of everything that's going on, I feel so privileged, so lucky that we have a virtual tool that's accessible to as many people as possible in the state of California. All you need is a zip code, and then we ask you the age of your kiddo so we can ask assessment questions. I'll just add, my background is in international human rights and social justice. Prior to Brightline, I spent a lot of years figuring out how to get people connected to services, and it can be really, really challenging and really hard. And so I just want to thank you all for being here. I know we're post-lunch, and we're just excited to chat.
That's fantastic. As you can tell, we've got a great panel, and there's a range of solutions here and a range of different types of companies. So I think we'll get to cover a lot of ground. But maybe from a starting place, we can kick off with a dose of optimism. Where do each of you see the biggest opportunity for technology to really make an impact on this system today?
Do we want to go in order or jump in?
Just jump in. Somebody start.
I'm happy
Noah's
to
ready.
start. I'm happy to start. First, I maybe just want to share some data points around how it has already impacted the system today. Bright Life Kids and Soluna were founded on January 1st, 2024. So I always joke that our program is a 2-year-old toddler. But in those 2 years, we have reached 330,000 registered kids. 77% of our families in care say that this is the first behavioral health support that they have ever leveraged. And they wouldn't be able to access it unless we were a virtual tool, right? So we are in 100% of counties. 65% of our members are from underserved communities. 73% are BIPOC. I mean, I think these statistics are staggering when we think about access to care. And so technology has allowed these communities to get that behavioral health support, but also to access it pretty quickly. So we're an average 2 days to intake, 2 business days to intake. I mean, you all are experts in the field. That's virtually unheard of for brick and mortar support. And then, you think about rural communities and folks that just aren't able, to walk into brick and mortar therapy. So we're just really lucky. And I think the other thing I'll just add is technology has really helped us triage care effectively, right? So Bright Life Kids uses a number of clinical assessment tools when someone registers. We use the BPSC. We have some postpartum depression assessments. And then the system, after a few minutes, will tell you you're a great fit for coaching or you need a higher level of care. In other instances, people are spending hours in intake, right? So just to highlight some of the success that we're really proud of.
I'd love to jump in just to connect the two programs together, and then I will connect to Charlie Health because we love our partnership with Charlie Health as well. So we see similar data as Bright Life Kids. Again, we've got our little 2-year-old toddler, Soluna, having a great time out here in California. We've got just over 143,000 adolescents and young adults on Soluna as of the end of 2025. 50% of them say this is their first time contacting anyone about mental health. And 1 in 3 of them say that if Soluna didn't exist, they wouldn't have anything. So I think to kind of piggyback on what Noah is saying and to really come back to this idea of California's investment in a digital strategy, what Bright Life Kids and Soluna appear to be doing based on this data is actually delivering on the promise of digital as an early intervention and prevention tool. We really are reaching people that otherwise aren't being reached because of geography, insurance, finances, stigma, etc. The stigma piece, I think, is important for our models because, again, there's an element of anonymity, which right now, for certain groups of folks in this country, is a really important piece of accessing care. So I think the promise of digital, it's agnostic to geography, both. We're here to talk about workforce, right? So we're agnostic geographically for where our workforce is in the state, but also it's agnostic for the service user themselves, and it provides this much more flexible way of accessing care. And then I think the second really amazing thing that we're seeing, and is something that I want to sort of say thank you to our partners, including Charlie Health, is how we are able to connect with other elements of the system of care. So we have a care navigation feature. We recognize that young people sometimes need more than what Soluna can provide. So how do we connect to them? How do we make sure they don't get lost in the cracks? And what we've done is we've created these partnerships, these affiliate network members, where we have these friendship agreements where we can do closed loop referrals as appropriate for that young person based on what they need. And one of our favorite partners is Charlie Health, and we've done a really beautiful job working together on how to make that referral actually work, right? Talking about interoperability, but also talking about workflows and how do we make it so that when we send something over to them, it makes sense in their workflow and we're able to give them the information they need. And what that means is that this young person gets kind of seamlessly transferred to the care that they need. So I think it's a digital front door, open access, and I think it's care navigation. So curious what your thoughts are, Caroline.
Yeah, I'm also thinking of two things. One is data sharing, right? So when it comes to data sharing and when it comes to outcomes, one of the most important things is to understand what are our clients' vital signs, right? Like when they come in, what are their vital signs? And when they leave, what are their vital signs? And have we at Charlie Health done a good job of keeping their vital signs healthy over time? And that the only way that we can tell whether or not our intervention is sustainable is if we partner virtually with the providers that we're referring to ensure that their vital signs are staying the same. And when I say that, I mean PHQ-9 and GAD-7, and what are all of the ways that we look at whether or not a client is healthy. The second thing that I think about with being optimistic about technology, we do a lot of matching. And so what that looks like is matching the patient to the best provider that there is. We know that there are certain providers out there that do amazing with 13 and 14-year-olds, but aren't great and don't feel passionate about 56-year-olds. But guess what? If they happen to show up to that clinic that day, they end up getting matched with that person. But when you're treating people virtually, you're able to match them to the person who is perfect for them. Can you imagine that we gave every person just a regular chemotherapy and that was it? You have cancer, you get chemotherapy. No, in medical, what we do is we say, okay, you need this dosage, this type of chemotherapy, and it needs to be really specific. And that's what we're able to do virtually that we're not able to do when it comes to brick and mortar, because we can match them with the perfect provider. Same goes with our group therapy. We're able to put clients with other peers that look and sound like them, that are struggling with the same condition, that are struggling with the same lived experience, so that way they can hear, me too, I've been there. I know what that's like. You don't get that in a brick and mortar. I ran brick and mortars, and you know what we had? An 18-year-old who was struggling with marijuana dependence, a male, sitting next to a 12-year-old struggling with trauma. That's what our group therapy looked like, right? But virtually, you get to match them perfectly with one another, so that way they know what it feels like to be seen. They don't feel more alone. They feel more connected. So that's just always, like, anytime that I go back to why virtual, I always just think we can do true matching that can make people feel more connected, because like loneliness is the biggest epidemic that we have here in this country, period.
And I think for those providers, that's kind of where my mind goes. The folks that are currently a part of this workforce that we're noticing are leaving the workforce. Hello, sorry, I left, right? Like, I'm not the only one. So how do we also support those who are maybe in those organizations in person, whether that's telehealth, doing group therapy, providing med management support, going out into the parks, doing crisis mobile. Folks who are doing this work day in, day out, how do we, for lack of a better term, like stop the bleeding? We need to add more to the workforce, but also support those who are currently in it today. And I think the optimism that I see is, in just last year, 115 organizations said, we're going to pull in this AI program because, we see what our clinicians need. And, I think that's of the 250 across the US in the last 5 years, what we hear from the folks utilizing Elios is that they're actually seeing better outcomes. So we've done randomized control studies that show that clinicians utilizing Elios see a decreased no-show rate, and they also see improved outcomes. Why is that? Possibly because they're actually there present with the client. They're not stressed about, okay, I got to make sure I write this down. What intervention did I just use? Because when they open up their computer, it tracked what interventions they used that day. It tracked the themes of the conversation. It's reminding them of these things. This is trained on 15 million minutes of behavioral health talk therapy sessions. This is specific for them and the work that they're doing. The fact that folks are saving 70% of their note writing time, often what we see organizations doing with that time savings is just giving it back to the provider. Go home early. Go be with your family. And for those that do have a wait list, and we might maybe get to this in the conversation, how can we increase care and see more patients while not burdening our staff? And they're seeing that by saving this time on the note writing aspects, they are able to see more folks. And so the fact that the patients, right, like I live in a community where 3 of the organizations in my community utilize Elios, and I drive by them and I see those patients outside of that clinic, and I'm like, they are getting better care. I know it because their clinicians are less stressed. Their clinicians are saving that time, that administrative stress. So I'm very optimistic to see the growth so far.
Fantastic. Yeah, I think we've heard so many different themes here, right? From the way in which, technology can help remove some of the administrative burden. We've heard about, the ability for technology to do matching and help put the right patients together, or the right patient and clinician matches. We've heard about the use of technology to essentially expand access with geography. Tell us a little bit more about, I'd be particularly interested in hearing from the providers, where else are you seeing technology as a tool to help improve the clinician experience? Yeah, I'd be curious to kind of double click there. Are you using scribes internally? Like, what else are you doing that's where technology is really unlocking the power of the clinician?
Yeah, so when we created our AI scribe, I went to our product team and I said, these are clinicians. I don't think that they're gonna like the idea that something's listening in. And they said, okay. And I said, so I think that we should make it a cat. And they said, I said, no, everybody loves cats, guys. And they literally looked at me like I had 4 heads. But I was like, I'm telling you, a cat, that's the thing to do. And we'll call it Charles, and he'll have a little bow tie. And so they created a little cat that sits in on our sessions. I thought to myself, it kind of sits behind, cats, they're always on your keyboard, right? They're always typing something. Anyway, it's not landing as well as I thought it would. Thank you, everybody.
Not a cat. I want to meet Charles.
All right. Yeah. So anyway, so what does Charles do? So Charles sits and listens and destroys afterwards, but puts everything that has been said in the session into a note that's specific and a template to Charlie Health. What he also does is will write a little note to the client saying something along the lines of, you did great today in session, so glad that we talked about X, Y, and Z. Now, obviously the therapist is gonna read that and they're going to edit it if they need to at any point in time, but they can send that to our client via the Care Center, which is our app that we have. But it's a way for the client to be able to hear what happened, and it's a way that helps to reduce administrative burden, right? Because typically then the therapist is gonna have to get off of that platform and get onto a new platform, and now they're gonna have to write new note, et cetera. It's very easy. It's easy to be able to communicate to clients in between sessions by using Charles and using our suite. In addition to that, one of the things that we've done that's really neat is we created what we call a risk radar. So we've been able to take all of the clients who have had a critical incident. Maybe they've hurt themselves, maybe they've gone to the hospital. We've been able to create a model that helps us to see some features that would help to predict if somebody is going to hurt themselves in the future. What we do with that is in the chart, we're able to say, this is a client that's more high risk, not based on a snapshot in time, which is how most is, right? You have your Columbia, you do your Columbia at the biopsychosocial, and that's it. This is throughout time, we're doing measurement-based care every single week, and every week that risk radar is going up or down depending on what's going on with the client. So that's another really nice tool for the therapist, because the therapist now feels like I have a really good indicator and a good window into what kind of risk that my client is struggling with. So those are just 2 things that come to mind. We have a lot of really neat things that help our clinicians, but I will have to be here for 2 days to talk about that.
Awesome.
Yeah, I think there's something about the experience of the clinician when they have sort of a trusted second set of clinical ears and eyes in the space, that they know, okay, I can be fully present with this person in front of me because I don't need to be worrying about capturing these things. And I think often about when I was in community behavioral health, I went from paper charts into an EHR into another EHR, but paper charts, doing an intake and paper charts when someone is trying to speak with you. But I also think it got harder when it turned into an EHR, because now this individual was coming into therapy, sometimes for the first time ever, right? How long does it take someone to make that first step to say, okay, I'm gonna move into this space and try to, care for myself in this way? And they're met with a clinician who's staring at a computer screen, while they're explaining their trauma history, their family history, right? And as a clinician, right, I went to grad school, I was like, I'm gonna change the world. And then I got in there and I'm sitting in an intake where all I want to do is, connect with this person. But my task is to make sure I collect direct quotes and answer all of these questions and check all of these boxes. And I think now about the folks that have this technology and how it allows them to do the thing that they kind of went to school to do, and the thing that brings them joy and satisfaction in their jobs, that they can sit and actually make eye contact with this person who's making this brave choice to come to therapy and share their story in this way during an intake, because they know that Elios is in the background capturing that to help them build that intake when they're all done. That's just one of the many therapeutic moments that, as a past clinician, I'm so glad folks are experiencing now.
I want to ask a question about this, actually, because I think a lot about...
I'm sorry, I'm the only one who's allowed to do that.
So sorry. I'm a troublemaker. Everyone knows this. Okay, but I'm going to do it anyway.
Please.
All right. So I think a lot about recruitment and retention as what you're, sort of speaking to, of like, how do we create opportunities for the jobs that we were trained to do to be more joyful and satisfactory? Because part of what burnout is it's the administrative burden, which also creates this barrier of seeing the outcomes that we came here to try to help get to, and it can lead to kind of this hopelessness and helplessness. So when I think about retention, that seems so clear. You've made like such a beautiful case. I'm curious how you think about recruitment, and as we think about workforce expansion, and we think about bringing, going beyond your clinician and your psychiatrist, right? We've got an incredible certified peer support health worker system in California. We've got incredible community health workers and wellness coaches. And these are folks who are able to come out into the community and do this service sooner, bringing some really valuable skills than it took me, a clinical psychologist. It took me like 6-7 years before I was really let loose to do this work. But then the opportunity for these scribes and these AI tools is that those folks can also move through their career faster, because we don't have to spend as long training people how to check the box and write the note. I mean, like learning how to write an intake summary was like a whole course in my PhD. It was like, let's teach you how to do this. But like, what if now we're able to move you through your training program faster, which means, and you can still do a great job. You can learn the stuff that changes people's lives, and you don't have to worry about how to write that intake report, because I don't think that makes you a better clinician necessarily. So what do you think about that in terms of like recruitment? Have you noticed that in the partners you work with or with the folks you're recruiting, that having those tools have made recruitment easier?
So I'm not a clinician. However, it's really interesting. We work really closely with our care team, and they're made up of coaches, right, in addition to therapists. And one of the conversations we have is about training and onboarding, right, in addition to recruitment. So I don't just think about like AI scribe and note-taking and the administrative burden, but also training with tools like Violet, diversity training, right? So now we can do this virtually, and we can make sure that people get extensive 80 hours of training when they join an organization because of a technology tool, something that was not necessarily, so quick in the past. So I think, and even you mentioned care coordination, right? Like, Now we know that a referral to a completely external organization is closed loop. It's not perfect. There's a lot of improvements that can be made, but these are tools outside of AI that have made, I think workflows for our care team a lot more efficient and also have allowed us to coordinate care. So when we can talk to someone who's going to join our organization and say, you have all of this available to you, I think it does make a big difference. And then the last thing I'll just add, which maybe is less obvious, but we have this close collaboration with our community engagement team. We work with all different types of schools, organizations. The fact that we're able to say, hey, hop on a 30-minute webinar virtually, meet coaches, meet community engagement members. That's another tool for engagement, right? We are teaching people about coaching beyond the registration wall and really opening up the door. So, we talked about this a little bit, but it's sort of the workforce behind the workforce, right? So let's not forget about our community health workers, our teachers, our promotoras who also want this information. And so just thinking more expansively about what it means to recruit people to the cause of behavioral health, I think is also important.
Yes.
Excellent.
It helps to recruit individuals. Charles especially, obviously. Who doesn't love a cat?
Huge win.
Yeah. No, the one thing that I do want to say real quick is when it comes to retaining, right? So yes, when we show potential candidates the suite of tech that we have at Charlie Health, they're blown away because we also build our own EMR, which has our own user interface, and it's beautiful. And but the other thing that they love and the reason why they stay at Charlie Health is because when they say to us, this button's not working, we fix it immediately. And that's because we have an in-house 50-person engineering team that will fix it immediately. So they're kind of, anytime that they, I think, talk about why our ENPS is so high, they talk a lot about how they feel heard and they feel valued, and that at any point in time we're doing that, but it's not an offshore situation. It's not a situation where we have to go to 5 other places to get a change, made. We're able to just do that in-house.
I love the question, Andrew, by the way.
Thank you so much.
This is really easy. I'm gonna just let you guys take it from here. We got it. Yeah.
No, I love thinking about this because it's not just about retaining who we have, it's about recruiting, right? And I had a call on my calendar and I was like, who is this? And I looked and they were head of HR and I was like, why am I talking to HR? Usually I'm talking to IT or, and they were saying, we need help recruiting clinicians. And we heard that some of the clinicians that were here went to the clinic down the road because they use you guys. And it has become this sort of badge that folks are listing that they utilize Elios on their careers page because it shows kind of an ethos or, a stance of how we take care of our employees, how we see this benefiting them. And so they put it on their career page. We use Elios. Here's what you get so that you can go home on time. And I think to your point of like, how can we think more expansively about the types of care, right? Maybe there are folks that speak Korean and speak Spanish and, over 100 languages that Elios is able to take in. You don't have to have perfect English to write this beautiful note because you can be having your conversation in Spanish, English, whatever it may be. And Elios will take that in and then provide you a well-written English note suggestions to build your note from. Or if you just went and visited somebody at their house and you're stuck in LA traffic, you can speak into your mobile device in whatever language you think best in. And it will take your brain drain, compile it into a note, and then you get back to your EHR and you then can use that note draft to edit and submit. So then what you're doing is you're saying, okay, great, peer specialists, don't worry about the perfect language. Folks who do not speak English as their first language, great, please. We need you to care for our communities that also don't speak English as their first languages and not worry about this administrative burden. So it's truly an equalizer. Even folks with ADD, I had somebody come up to me saying we had to release a clinician who was incredible at the work that she did, but she was very behind on her notes. And it's a part of the job to complete the notes because we can't get paid if those notes don't get in. And we had to terminate this person. if there was something there to support this person in writing those notes, maybe, you know, they would be able to stay. So again, that sign of like, oh, this is an organization from a recruiter standpoint that utilizes tools that will help me not only be better at my job, but maybe be able to expand peer specialists and folks coming from other parts of the community.
Amazing. Awesome. So we've covered all of the good news, right? Maybe we've got a little bit more to come, but you know, the sunshine, the kittens, you know, so on and so forth. Where is it not working, right? What are the barriers to technology actually having this impact that we're talking about here today?
I think there's a few places that opportunities for improvement that we can look to, and a lot of them are really active conversations. I think the first one is we've talked a little bit about the digital divide and digital equity and access. It's, you know, the Soluna Bright Life Kids program's incredible. Everybody has access to it on any internet-enabled device. That last part of the sentence is really important, especially in a place like California, where we have some rural counties where internet access isn't super great. It's not 100% in terms of like penetration for the population, and cell service isn't great because there's like 4 mountain ranges it has to go through. So that has to be solved, I think. And that is a collaboration with policymakers and wireless providers and local county supervisors and the people who make the decisions about broadband access, as well as the behavioral health providers. So I think that to solve that big problem is a systems collaboration challenge. And I know those conversations are happening, and they need to continue to happen. And then I think the other one that, you know, it's an elephant in the room that we talk about a lot with our partners, which is here I am at Soluna saying, hey, we recommend that your adolescent kid get on their cell phone and download this app and access it for mental health support at a time when we are having an active conversation about screen use and phone use and being online as a young person. How do we thread that needle? And the way that we're thinking about it is that the truth is that young people, nay, all of us, are going online for information and community. So how do we make it safe community and credible information? And I think it's through really thoughtful design and well-regulated platforms where young people, like the service user themselves, are part of that design, and you create these guardrails so that you're providing an online space that they know is safe and is providing them credible information. And I think that bit of the conversation, how do you make it safe and credible and reliable, is one of these key areas of opportunity across the technology solution, right? It's a big part of our generative AI chatbot discussions, but it's also a part of what it means to just be online in spaces with other humans. So I think that's a huge area for opportunity, and it's an area that we talk about a lot with the young people that help us continue to iterate on the platform.
I'm happy to go. You know, it's funny because I'm a telehealth convert. I actually did my dissertation on the use of technology in a therapeutic setting. And my entire dissertation was about how much providers hate telehealth. I wrote it, and I'm not kidding. I sat with 40 social workers and providers who I sat there and I said, what do you think about using technology in a therapeutic setting? And they said, I hate it more than anything. They said, my clients go on vacation and then they get onto Zoom with me, and like, I don't even know how to use Zoom. This is pre-COVID, right? Anyway, so what happened to me though is that overnight, I had to move all of my brick and mortar intensive outpatient programs to virtual, right? We all were there. March 23rd to March 24th, a Tuesday to a Wednesday. I'll never, ever forget it. I went to sleep the night before crying myself to sleep thinking tomorrow's the day that I have to lay everybody off. There's no way that any of my clients are going to show up on Zoom for 3 hours a day. I mean, that's crazy. And we opened up the Zoom and suddenly, boom, you know, we had better outcomes. We had higher attendance. I was treating mostly adolescents, so parent participation in treatment is the single largest indicator for positive outcomes, and parents were more likely to show up to sessions, right, because they were at home because it was COVID. So we would say like, hey, Savannah, is mom around? She'd be like, yeah, she's in the other room. We'd be like, great, can you bring her in? Just her stepping in, right, to the room changes the outcomes tenfold. So I became a telehealth convert. Guess what? So did all 40 of those people. Like, how about that none of them have offices anymore? They're like, I said something to one of them. I said, hey, remember that time? And they're like, yeah, I can't believe that that's how I felt. It's crazy. I love telehealth now. I can see my patients when they go away. I can see people that live in rural areas that I never thought would get high quality care. And here they are getting high quality care by me, you know. And so that happened, and we all became telehealth converts in a lot of ways. But unfortunately, policy never followed that. And unfortunately, there are states that still have regulations that were written in the 90s that we all have to adhere to that say that we need a brick and mortar. I mean, and it's wild, right? Because we have so many individuals in this country and in this state that need multiple time-a-week care, that are struggling with suicidal ideation or struggling with substance use, but they can't drive a half an hour. That's crazy. They can't leave work early. They don't have a car. I mean, they can't come from 3 to 6 Monday, Tuesday, Wednesday, because that's all that they offer. You know, at Charlie Health, we offer times all day, every day. Every single day, you can come to Charlie Health at any point in time, and you will get 3 hours of group, and you'll be matched with other peers. So my point is simply that, like, the biggest problem that we're faced with is policymakers and so many regulations and so much bureaucracy that is not accepting of telehealth and virtual treatment, and it's not fair to Californians across the entire state. It's just not fair. Like, we have to be able to provide them high quality treatment and not adhere to necessarily one sentence that's in a policy. It's just not fair. So that's my rallying cry.
Woo! That was good.
Yes,
I too am a telehealth convert, and I think I want to go back for a second and talk about the digital divide as someone who runs a community engagement field marketing team. I think in 2026, we kind of just assume like everyone has access to great internet, and it's really not the case. I have colleagues, I don't know if folks out here anyone from Southern California, but out in LA, I have a colleague who goes to Lancaster all of the time. We are a technology tool. We go out there with QR codes. Sometimes there's just no internet. It just doesn't work. And so I think the existence of my team is enough to indicate that sometimes human beings are the only ones that can solve these really human issues. And technology is a tool that connects, but it can also separate, right? And so we just need to be really conscious and mindful of the communities we work with, what they do have access to, what they don't, and problem solve really creatively around it. So for example, we have, partners who say, you know what, our parents and caregivers don't have private laptops at home. Can we partner with the local library, figure out how to get them a private space, set them up with internet? Can they do their sessions there? And we have these really, creative chats about solutioning, and we rely on our community-based organizations and other partners to do that. So I don't think we should dismiss the fact that it's not an obvious, right, that people need to register with an email. And so we have a member services line, but I think this discussion around internet, the digital divide and access is going to continue to come up.
I think we're doing pretty good here at Elios with some of these things, but we weren't always there, right? And so what I love about AI technology is how quickly you can develop it, because it's AI. It's still kind of over my head. I'm a therapist. Like, I don't know the tech side of things. But what's incredible is, like, we needed folks to go to homes where there was no internet and still be able to utilize this. And now our mobile solution has offline mode. And we needed to make sure that we were regulating what the AI was bringing to us, that it wasn't full of bias. And so we need to continue to train our models on very diverse data sets. And so we have to keep these things in mind. And I think the market is technically flooded now with AI scribe solutions and things of that nature. And I think one of the hurdles now is I take it really personally because I see the goodness of what clinicians are experiencing, like going to their supervisors in tears saying, thank you so much for bringing this here. This has truly changed my job. And then having conversations with certain counties that are saying, oh, we don't use any AI for providers in this county. And it's not any AI. It's a specific AI built for behavioral health that is highly secure, vetted, and the Cal Mesa AI vendor. But there are hurdles that I think, one, we need to make sure that in this flooded market, I don't blame counties for making sure that there's regulations, because there is so much out there that isn't thinking about the bias, that isn't thinking about the security, that isn't thinking about the outputs. And is there space for the products that are? Because this is changing the lives of clinicians, and we're already in this place where we are losing folks in the workforce. And so how do we give this tool not only for them, but for the patients that they serve?
Awesome. What do you think are the biggest misconceptions here when you talk to people? What are the biggest misconceptions around technology and its application to behavioral health more broadly?
Oh, the most common question that I get is, are you, and sometimes the question is not asked directly, but the question behind the question is, are you going to replace me? Is technology coming along to replace the work that I do? Or take the clients that I see, which then takes my revenue, which then gets rid of my clinic. The concern is the robots are coming to replace the humans. And I don't dismiss that concern. And I think the challenge for us as a field is to really catch ourselves and avoid thinking in kind of black and white terms, like it's all technology or it's all human. I think the future is hybrid. And actually, I think all four of us on the stage are essentially talking about the ways that the technology that our groups support are providing hybrid solutions to support the workforce and the clients that we serve. And so I think the conversation that I end up having with folks when they express this concern is, no, let's talk about how technology can enhance the work that you're doing, can extend the work that you're doing, can help you serve more folk, or help the folk that you do serve feel better faster. So, for example, nearly 50% of our coaching sessions are happening outside of 9 to 5 hours. So if we partner with a local brick and mortar CBO who tend to see their clients between the hours of 8 and 6, they now know that their clients have also got access to skills, tools, and coaching support when their clinicians have gone home and are hanging out with their kids and walking their dog and not worrying about notes or clients. So it's about extension of the system of care, enhancement of the system of care, not replacing the system of care with a new solution.
Yeah, we say augmented intelligence rather than artificial, because we're trying to give clinicians a tool that really doesn't replace them. It does the opposite. It makes sure that they stay. And I think a misconception is, oh, this is diagnosing the client. It's writing the entire note on the clinician's behalf. There's no room for clinical assessment, clinical judgment. None of those things are true. We actually serve up bite-sized pieces that you read and build, and it's your note, and then you submit it. And also that that sort of like privacy and the fear, right? I always thought of my therapeutic dyad as this spiritual space. It's personal, it's sacred. And how are we inviting technology in this way? But from my stance, because we're not recording and because you're actually able as a clinician to be more present, it's almost enhancing that experience. So I think there are some misconceptions. Similarly, is this coming for my job? No, we're trying to make your job more manageable at the end of the day.
Echoing exactly the same thing. The only thing that I want to add is that one misconception that we've heard from our therapists are things like, is this going to be used against me in my performance review? Or is this something that you're going to start to control me using, right? Or are you going to start telling me what interventions to use? And of course, the answer is no to all of it. And true or false, most of us put emails through ChatGPT and say, make it sound better, right? So it's like, how can we make it sound better, right? And all that I can say is I think that a lot of those fears make a lot of sense. And like you said, we don't ever dismiss them because it makes sense. And we're not going to use it to control you. We're not going to use it to stare at your sessions and figure out what you're doing wrong. That's not the goal here. The goal here is to make you more efficient and happier and more present with your client.
I just want to very quickly jump in because I love this point that you're making. And one of the things that we've done at Soluna, and it's sort of a core value of Kooth, is flipping that narrative of how can the fact that we are keeping records of all of your chat sessions actually help you continue to be the very best provider that you want to be. And what we do is we connect that to our clinical governance, our fidelity model, and then we work with our coaches to look through like how is the kind of gestalt of what you're providing aligning with the fidelity model, and what additional support or training or supervision would you like to continue to provide the very best quality of care that you came here to provide. And so the narrative is not we're watching you and doing a performance review, it's we're looking at the work with you to help you continue to be really good at your job, so that any consumer that drops into the chat queue can trust that no matter which coach they're talking to, they're going to get high quality care because that coach has had really meaningful supervision. There are a lot of providers in this room, a lot of former providers. I also flew the nest. And I like to say that once I got my license, really nobody came to check in on me and make sure that I was still doing good work. It was just sort of assumed that I was. And I actually found that frustrating as a provider. I wanted people to come and look at what I was doing and tell me how I could do it better. And I think technology affords us to do that and make the quality of care that we're providing better. But it's a needle to thread. I can see that from the performance review perspective. Sorry, Noah, for taking a piece of your mic time.
No, I'll just, and I think there's this really funny misconception that our coaches are just a bunch of AI chatbots. And I don't blame folks. They hear behavioral health virtual services. And I think, unfortunately, youth are reaching out to ChatGPT for behavioral health support. So it's not a wild thing to consider. But if you know our coaches, it's really funny because they are from their communities. They come in with such extensive experience knowing how to work directly with communities. And so I think it's just important to remind folks that, yes, it's a totally virtual service, but these are real human beings with real lived experience who reflect the diversity of California and are really here to support you. And so I think it's really important to keep that in mind. And then I'll just add another big misconception is, oh, you're just an app. And so I just really want to double down and say this is such an extensive program that has considered how do we meet parents and caregivers where they're at. You're not ready for one-on-one care? Try out a digital tool. You don't want to do that? Try a peer community. You want to chat your coach in the middle of a grocery store? Do that, right? And so I think it's just really important to remember that there's been a lot of thought and care put into how do we leverage technology to connect folks, and that technology is a co-pilot, right? And that there are still human beings who are driving these engagements.
Yeah, absolutely. Well, to bring us home, I mean, it's so clear the space is moving so incredibly quickly. Like, as you mentioned, we went from nobody knowing what ChatGPT was to hundreds of millions of people out there using it for various kinds of emotional support today. Good thing, bad thing, complicated, right? But, really, so from your lens, you're sitting sort of in many cases at the cutting edge of what's happening at this intersection of technology and behavioral health. Maybe give us, like, each one of you 30 seconds real quickly as we wrap here about where you think we could be in 2 years and what's possible here.
Ooh, in 2 years?
2 years, soon.
Oh, that is a soon timeline. I think that my hope is that in 2 years as a field, we will have made progress on two aspects that I think are necessary for using AI for good when it comes to direct service. I think we've done a really good job of solving AI for good when it comes to administrative pieces. I think the first thing is in the design and the building of these generative AI chatbots that are being built to provide behavioral health support, we need to have more people at the table. The folks with lived experience need to be at the table. The clinicians that provide the services need to be at the table. The administrators and system workers around that need to be at the table to make sure that we are thinking through guardrails and safety and interoperability and also quality of care. The old adage of like the model is only as good as the data you put into it. And I talked a little bit about this last year that like honestly, there really is a lot of disagreement in mental health services about what is good treatment. So how do you know what is good data? So I think you need to have more people at the table to do that. And then I think the second thing is regulation. We need clearer regulations from a policy perspective on what it means to be safe when it comes to a generative AI chatbot? What does it mean to be credible? What does it mean to be evidence-based? We have not answered those questions yet, but I think my hope is that in 2 years we will have answered at least some of them.
Yeah, I think to provide a solution to some of my earlier frustrations is I do think in 2 years we could see many policies and rules being put in place that do allow the ease of use for, you know, an organization like LEOS to come in and support clinicians because there's policy, there are rules, there are boundaries, and you know it's safe, you know it's been vetted. I also think, and maybe this is personal, but I think we're going to see the burnt out clinicians of the past coming back. I think that it's becoming more manageable. We don't ever lose our heart for the care. It just wasn't doable. And so with technologies like this, with platforms that you literally can be anywhere, I could spend my chunks of time part-time. Like, I could do this because there are platforms that allow me to work from anywhere, to maybe work in several different places. And that's really exciting to me.
Yeah, I might consider coming back. Get some ideas. Yeah.
My hope for the future in 2 years would be that if you are any person, anywhere, no matter the county, you are able to get accessible, affordable, high quality care, period. You don't have to pay thousands of dollars to get that care. You don't have to sit on one wait list. You get the care immediately. You get in for a 90-minute evaluation with a licensed clinician, not a bot, and you get matched to a clinician who is perfect for you with other peers who are perfect for you, and you're able to have a decrease in symptoms that get consistently tracked. And when you leave that care, you continue to get tracked throughout time. So that way we can make sure that the vital signs of your behavioral health symptoms continue to decrease over time through the use of data sharing between organization to organization.
When I think about it, you know, in 2 years, one thing that I'm hopeful for is the continued destigmatization of getting access to care. I think especially with a virtual service, we always talk about this, like there's no playbook to parenting. I'm a mom, my kid was born, I don't know what was happening, and I didn't have Bright Life Kids. No one was walking, you know, me through the process of becoming a parent. And so I think we didn't talk about this extensively, but closely related is in a couple years, we're going to talk about coaching and subclinical programs a lot more. You know, there are a lot of families, they don't want to talk about therapy. They don't want to talk about higher acuity care, but they'll have a conversation about just getting support on your kids' tantrums, right? They'll talk about big feelings. They'll talk about, oh, little Timmy bit someone at school, I need some help there, right? And so I think we'll see that normalization hopefully a lot more in a couple years, and I'm just really excited for that.
Amazing. Well, please join me in thanking the panelists.
Thank you.